Thank you, dear Rani, for those kind words. Rani is just not a family member. She has been my very good friend right from I don't know how many years. So, a very good evening and namaskar to all my seniors, my dear colleagues, and my own family. Thank you for being here. So, let's start the talk. I think it's not working. At the outset, I would like to thank the lovely PCDA family for giving us this wonderful opportunity this evening. I would like to take this opportunity to thank my mentor, Dr. Dilip Varke sir. He has been a guiding light through our thicks and thins. And this is our dream team. All of us are here. Thank you so much for being here. Let's start a topic. Infertility, which is inability to conceive within a year of intercourse without contraception. So far we know that the definition of infertility is when a couple is trying to conceive for 1 year, not using any contraception, is not being able to get pregnant, is defined as infertility. Does it affect only females? No. So far, we do have adequate statistics to say that it affects males and females equally. Infertility management. Infertility management, when the problem is so big, what are the fertility management strategies that we have? We should be doing a detailed couple evaluation. We should be focusing on improving the general health, understanding treatment options, understanding who needs what, a detailed and thorough counseling, and motivating them to choose the correct treatment option. So, when to investigate? Ideally, when a couple is trying to conceive for more than 1 year, it's the most ideal time to investigate the couple. But if the couple has been trying for less than a year, we should be telling them about the fertile period. We should be explaining them the cumulative chance of conception in one cycle, the cumulative chance of conception in one entire year. Still the couple wants to get evaluated, no harm in going ahead with the investigations. To start with any investigation, to start with any evaluation, it should start with a detailed and thorough history taking. History taking should always comprise of detailed menstrual history, obstetric history if any. Is the patient taking any of the medical medicines so far? Is there any surgical history so far? Occupation pressures, addiction. Examination should start with observing the female for its body mass index, her BP measurement, acne, hirsutism, presence of secondary sexual characters, presence of galactorrhea if any, and signs of hyperthyroidism. Evaluation of female in terms of blood workup should start with a basic hemogram, random blood sugar levels, HIV, HbSAg, HCV evaluation, day 2 FSH and LH, AMH hormone, ultra TSH, serum prolactin, and a basic good health to determine vitamins B12 and D3 and rubella immunity check. A female scan, the baseline scan should never be done with a transabdominal scan. It should always be done with a transvaginal scan with an empty bladder. A baseline scan should be done on cycle day 2 or 3. And if you're sending the patient outside for a scan, be sure that you ask the radiologist to count the antral follicles in each ovary. Not just the antral follicles, he should be measuring the cyst, he should be measuring the ovarian volume, the stromal content, the size shape of the uterus, fibroid if any, and the distance of fibroid from the endometrial cavity. So this is how we can peep into the female's uterus. Then comes the evaluation of tubes and uterine cavity. Tubes and uterine cavity can be assessed with the age-old conventional HSG, which is really painful. Then comes the saline infusion sonohysteroscopy, or the gold standard, that is diagnostic hysterolaparoscopy. These days, the personal choice is going ahead with SSG because it can be done under general anesthesia in OT under the USG guidance. Of course, diagnostic hysterolaparoscopy becomes the gold standard, but yes, it comes with a cost. Evaluation of male as well should start with a detailed history taking. We should be asking about the addiction history in detail, more so in the absence of wife, because most of the times they don't accept that they are addicted to something. Go ahead with the examination of BMI, blood pressure, hair distribution, at times the secondary sexual characters and signs of thyroid disorder. Please do investigate them for hemogram, basic sugars, HIV, HbS, HCV, thyroid and vitamins. Of course, the most important test for males become the semen analysis, and according to the WHO 2010 criteria, we need the sperm concentration to be at least of 15 million per ml. Total motility of more than 40%, progressive motility of 32%, and sperm morphology of 4%. When to investigate the males in further detail? Whenever the males are more than 40 years of age, if the sperm count has been less than 5 million, if there are known cases of hypertension, if they are diabetic, if they are hypercholesteremic, if they are chronic smokers, if the wife has been facing repeated pregnancy loss, or if there has been repeated implantation failure, or the couple is an unexplained infertility couple, then it becomes a good idea to investigate the males as well in detail. What do we see in them in that detail is karyotype, Y chromosome microdeletion, a USG scrotum to rule out the varicocele, hormones like testosterone, FSH, estradiol as well, and prolactin. Sperm DNA fragmentation index is the new kid on the block, which gives us an idea. Even if the sperm concentration is good, at times the DNA fragmentation index, if it is high, it gives rise to repeated abortions. An andrologist opinion can be taken. Next, in infertility management comes improving general health. So there cannot be a pregnancy unless and until the basic general health of the couple is good. To improve the general health, a healthy, well-balanced diet, which should include fresh fruits and nuts, moderate regular exercise, at least 20 to 25 minutes of exercise daily. We should encourage the couple to maintain ideal body mass index, quit smoking, stay away from the phones and laptops whenever it is possible. Try to encourage them to have sunlight exposure to at least 20 to 30 minutes daily, and put them on multivitamin supplements wherever possible. Next comes, after evaluation, understanding the treatment options. What are the options available? Who needs what? The first and the basic option available for the infertile couple, for young couples who have normal ovaries, who have AMH as normal, who has the antral follicle counts as normal, whose tubes are patent and semen samples are normal. This should be tried with the ovulation monitoring with timed intercourse. Now, ovulation monitoring with timed intercourse should always begin from second day of the menstrual cycle. Many a times we get a call, a random call from the patient that I'm on the 10th day of the cycle, I want to see whether I'm ovulating. But that's not the correct thing to do. The first scan of ovulation monitoring should always be documented on second day of menstrual cycle. Avoid doing natural cycle follicular monitoring. Always prefer to use an ovulation induction drug. Why? So that the subtle ovulatory disorders are corrected. Please always give them a trigger shot before making them trying to conceive. Why? Because trigger shot will always ensure the ovulation within 36 to 42 hours. And they can time the relations properly. Whenever we give the trigger shot for ovulation monitoring cycles, we should ensure that the triggers are given in the morning. Why? Because the 36 to 42 hours in that way will fall in the night hours, in the evening hours when the couples can make it together. If you give it in the evening, the 36 hours will fall in the morning, wherein the couples will go for their jobs. So advise intercourse at least for 3 days post-ovulation. Try to give a luteal support, and maximum 4 to 6 cycles to be tried this way, not 12, 13, 15 cycles. Next comes ovulation, intrauterine insemination. As Marquez has mentioned, that IUI has to be done only and only in level 1 ART clinic or IVF centers. So we are not supposed to wash the semen sample from a pathology lab, get the semen sample at our clinic and do the IUI. So indications for IUI should be the age factor of the female, which should be less than 35 years, normal ovarian reserve test, at least one tube has to be patent, the normal or mild male factor. Always the ovulation induction for IUI, the focus should be to make at least 2 to 3 follicles. Because if we make only one follicle, it's as good as natural cycle and it would not increase the chances of conception in IUI. So the rationale behind doing IUI is to concentrate the sperms and more number of oocytes at one time at one place. And we have to time everything in a way that they reach at the same place at the same time. So targeting 2 to 3 follicles would increase the chances of conception, but yes, we also have to tell them about the chances of multiple pregnancies. Trigger should always be given when the follicle is more than 17 mm and the endometrium thickness is more than 7 millimeter. Now for IUI, most of the clinics work in the morning, so the trigger shot should fall in the evening hours. Plan your IUI after 36 to 42 hours. Timed intercourse post-IUI, at least for 2 to 3 days, will again increase the chances of conception. Please do give luteal phase support, and the best treatment cycles are the first 3 cycles. I mean, the majority of the couples would conceive in first 3 cycles itself. Then comes IVF ICSI, or commonly called as test tube baby. Indications for IVF are age factor of the female always. See, like age is something that we cannot change, and age is something that should always be taken into consideration while taking any decision about infertility treatment. So when the age is more than 35 years or the ovarian reserve tests are abnormal, like the AMH is very less or the antral follicle count is very less, the patient should be subjected to ICSI. Bilateral tubal block, severe male factor, and unexplained infertility. So what do we do in ICSI? Whenever we retrieve the eggs, into each good quality of egg, the sperm is inserted. Was that visible? This is the sperm over here. And we insert the sperm into the oocyte. This is how we fertilize the oocytes into IVF lab. After fertilization, the blastocyst culture is done. That is, the fertilized oocytes are kept into incubators. These are particularly the high-tech benchtop incubators to maintain the controlled condition as far as possible close to the mother's uterus. Blastocyst transfer offers the best success rates. Newer techniques available are laser-assisted hatching. Sometimes the outer layer of the embryo, that is called a zona pellucida, is very hard and thick. It could be because of the inherent quality of the oocyte or because of the freezing and thawing process. Now these things make implantation difficult. So in laser-assisted hatching, what we do is we make a small opening on the outer shell of the embryo, and this assists in implantation. We do this just prior to embryo transfer, and this improves the chances of implantation. If you can see here, we have given a laser shot. So this will help the inner cell mass to come out of the zona pellucida and implant into the endometrium. Newer techniques, pre-implantation genetic screening. In pre-implantation genetic screening, which is also called as embryo biopsy, it involves retrieval of few blastocyst cells to check for the chromosomal normalcy. So this is the blastocyst that we have. We try to do biopsy. We insert a needle. We retrieve few cells of the inner cell mass and we send it for chromosomal normalcy. So this is how transferring the chromosomally normal, that is euploid embryos, would improve the chances of successful implantation, as well as it will reduce the chances of early abortion. The most important factor in infertility management is, of course, the counseling. Problem of infertility in itself is very stressful, that every female coming to the ART clinic always thinks that why is it so that my cousins have conceived so easily, my sisters have conceived, my friends have conceived, and why have I ended up into an ART clinic? So an ongoing emotional support throughout the evaluation and treatment is mandatory. Always focus on couple and not on a single partner. Like even if there is a partner in male, you should be always telling the female that you also improve your oocyte quality so that the chances of conception would be better. Otherwise, they would have that guilt conscious and or else the disharmony in marital relations. Guide them through best treatment options available according to the investigations that you have done. And please provide them with accurate information, because there is lot of misinformations in the society about the fertility treatment. Usually goof-ups do not occur into fertility centers. There are checks at multiple levels to see that the semen parameters, to see that the semen samples are transferred in the proper patients only. Sir has already spoken about Vicky donor. I would not repeat. Vicky donor, if I remember correctly, he has produced 22 babies out of his semen sample, which was not allowed even in the previous law. So movies are made only for entertainment. So please dispel the misinformation passed on in the movies. Motivating the couples to choose the correct treatment option is the most important thing that a fertility management consists of. Most importantly, help them take the best decision in time, because biological clock would not wait for anyone. It would keep on ticking, and I'm sure that the couple will thank you for the rest of their life. Thank you so much. Thank you for the patient hearing.